The next topic where we left off is spermatogenesis, which is the making of sperm. It does involve hormones, so we'll go over that. I want you to make sure that you pay extra attention to hormones. There's a lot of hormones on the final exam, not just from the endocrine chapter, but we've talked about hormones like all the way through. So just make sure that you have those down. You still have your flow chart, which you should, and if you've been adding to it, make sure you study those. I will say for the final exam, the old material is going to be more surface level, so it'll be easier questions on the old material. The harder questions are going to be reserved for the new material. But you still got to study. All right, so there are a couple different pathways that are happening here. I'll go through the diagram here step by step, and then there's like two little flow charts in your lecture notes for a more simplified version. But, yeah, I'm recording it. So the hypothalamus releases GnRH. GnRH stands for gonadotropin releasing hormone. So GN, capital G, lowercase n, RH stands for gonadotropin. I know how to spell releasing hormone. And don't forget that all of our releasing hormones, like thyroid releasing hormone, growth hormone releasing hormone, and this gonadotropin releasing hormone, they come from the hypothalamus. All right, so the hypothalamus releases this GnRH. GnRH causes the anterior pituitary to release FSH and LH. And if you don't remember from the first or second lecture we had, FSH stands for follicle stimulating hormone, and these come from the anterior pituitary. And LH stands for luteinizing hormone. That's not how you spell luteinizing. Okay, and so those are going to go off on two different pathways. FSH indirectly stimulates spermatogenesis by causing what are called cystinocytes to release something called APB. Or ABP, sorry. ABP, so you're going to learn a lot of acronyms today. ABP stands for androgen binding hormone, or protein. Androgen binding protein. And remember, these are all hormones, so you can use abbreviations on the exam, but just so you know what they stand for. So the FSH indirectly causes spermatogenesis by causing cystinocytes to release ABP, which is going to keep local concentrations of testosterone high. High testosterone levels mean more sperm is going to be created. And so on the other pathway, that's this pathway. So GnRH is released from here. The anterior pituitary releases FSH. That FSH causes the cystinocytes to release ABP. ABP keeps testosterone high to keep sperm count high. On the other side, the anterior pituitary at the same time is releasing LH, luteinizing hormone. Luteinizing hormone directly stimulates interstitial endocrine cells to release testosterone, which is essential for spermatogenesis. So one is causing the release of testosterone, the other one just keeps testosterone levels high. Okay, and so we'll go over the simplified version here next. One thing to know, though, is testosterone acts at other body sites, not just at the gonads or the testes, because it's going to stimulate secondary sex characteristics. It's going to stimulate sex drive. It's going to stimulate the maturation of sex organs as well. So testosterone doesn't only have a hand in spermatogenesis, or the making of sperm, also has a hand in other reproductive structures and processes. There is a negative feedback by testosterone. If testosterone is too high, there is a negative feedback loop to the anterior pituitary and to the hypothalamus kind of slow things down if testosterone gets too high. You already know there's always a need for a balance and homeostasis, so there's always going to be a negative feedback loop if we have too much of something. And that's all for that. But so let's go through that simplified version of that diagram that you have in your lecture notes. So the first one is FSH, which is released by the anterior pituitary, leads to ABP release by cystinocytes, which is one of our 4 cell types in the testes. This just keeps levels of testosterone high. Keeps testosterone high. Testosterone high. And keeping testosterone high keeps sperm levels high. The other pathway, LH, which is also released by the anterior pituitary, causes testosterone release by interstitial cells. And this directly causes spermatogenesis. And so these 2 pathways work synergistically together to keep sperm count high. So one thing to know is this is an indirect pathway. It just makes sure that testosterone stays high to keep sperm high, but this pathway here is direct. It directly causes the release of testosterone, and testosterone is what's going to cause spermatogenesis. So one is a direct pathway, the other one's an indirect pathway. So some of the secondary sex characteristics for males. Include pubic, facial, and axillary hair. Also, if you happen to have high levels of testosterone, you'll also get a good amount of chest hair as well. It's going to cause an enlarged larynx. And that accounts for males having a deeper voice than females. And then having a larger, what is the structure at the larynx that sticks up? The laryngeal prominence. So it allows for a larger laryngeal prominence. Yeah, I think so. I think I ran out of room for that. So just make sure that you know both males and females will have a laryngeal prominence. It's just that males will have a larger one due to the testosterone. I'm not done. Oh. There's more. Oh, no, but wait, there's more. Can I erase the pathway so I can write down more characteristics for you guys to write down?
Good. Yeah.
Good now? Okay. Oh, that went away. Okay. Well, good thing you took a picture. So you took a picture of the other secondary sex characteristics, right? Or you have them down. The other ones include males will have thicker, more oily skin. That's why while they're developing during puberty and testosterone levels are really high, they tend to have more acne. Females tend to get more acne later in life. Not always, but for the most part. They're also going to have a higher bone density than females, which is why females are more prone to osteoporosis, especially when estrogen levels drop. And then they also will have larger size and mass of their skeletal muscle. So in general, males are stronger than women because of their testosterone levels. Not accounting like training. Obviously, if you work out, you'll get more muscles, and you could be stronger than a male who doesn't have high testosterone levels or high bone density or muscle mass, but in general. I always try to act like I'm stronger than my husband, but I'm not. I really try. I try to pin him down. He's like, you're never going to win. One of these days when we're really old and I'm still going to the gym and you're not, it's going to happen. All right. Just a quick review, and you guys wrote this down, right? What was your question, Susie?
Professor, I'm sorry. What if they're like short and small? Because I've seen some small guys.
Yeah, that all has to do like with growth hormone. I mean, everybody's levels are going to be different, and so you will have shorter males versus taller males. I mean, it's all genetics and hormones and such. But on average, if you took an average height male and an average height female, not considering anything else, the male would have a higher bone density and more skeletal muscle mass than a female. But there's always going to be variation. Now, one thing I want to ask as a review, GnRH, that comes from the hypothalamus, which is a nervous system organ. So what do we call those types of hormones that are released from the hypothalamus? Neurohormone. Don't forget that. Okay. This is the development of sperm. I don't need you to know the entire pathway, just the basic pathways, because it's going to be very similar with females. But the first step, and this is in your lecture notes already, is a spermatogonium. That is the stem cell. So that's where all sperm are going to start off from. It's a spermatogonium. So it's just a cell. There's no head or flagella, none of that yet. And then we have primary and secondary spermatocytes. These are going to happen during meiosis. So this development happens during meiosis. Make sure you know this is a stem cell at the very beginning. Then we have what are called spermatids. You don't have to know early and late. You can just call them spermatids. But they're going to develop into this form during maturation. And even though they have started to form flagella, they are not motile yet. So while they're still spermatids, they are non-motile. They can't swim yet. Once they get to the spermatozoa, that's when they're fully mature and motile. So spermatogonium to a primary and secondary spermatocyte, which is during meiosis, which is going to happen in the testes, to spermatids. Do you remember the structure where I said maturation of sperm is going to happen? When we talked about pigs? The epididymis. Okay, so the epididymis is where that maturation is going to happen. And then when they're fully mature, we call them a spermatozoa.
So motile is the same as mobile?
Motile, yeah. Oh, okay. When we talk about like biological structures like that, it's motility and not mobility. Mobility is more set for humans versus cells. But you can use them interchangeably. I know what you mean. Okay. So this is a micrograph of a seminiferous tubules. All of your stem cells will be on the very outside, and they're going to move this way as they mature, and you can see the development of the flagella in the middle there. Isn't that crazy?
What causes them to move so fast?
The flagella, this is how flagellas work. They have mechanical proteins that allow them to wiggle and move.
But they wiggle in no direction, right?
Yeah, they're just going. I mean, they're shot in a certain direction, so they're going forward, but they're not going in any particular direction, yeah. So it's all chance of if they're going to meet up with the egg or not. Okay, so these next are the ducts. So all of the passageways used to transport sperm and semen. So the epididymis is the site of sperm maturation, which happens over the course of about 10 to 12 days. And then it's also the site of sperm storage, which is a little over a month. If the sperm are unused, they deteriorate and they are phagocytized, and we just recycle the parts and use them for something else. So I always say for females, don't let a man manipulate you because of blue balls. Say, give it a month, so it'll go away at some point. Give it a month. It is a real thing. I mean, they do get like inflamed and it's uncomfortable. Females, same thing. If a female doesn't orgasm, that clitoris stays really swelled up, and it is uncomfortable. So it's uncomfortable for both. It's just the testes are just, there's more mass, so it's not that it's more sensitive because the clitoris is just as sensitive, but it's just more tissue, so you feel that uncomfortability for a longer time. Next is the ductus deferens or the vas deferens. I did mention before that we're going away from calling it the vas deferens. People still do, but vas is technically incorrect because vas means vessel, and this is not a vessel, it's a duct. So it's been renamed to the ductus deferens, but I'm okay if we use either one. One quick thing about the epididymis. What's really interesting. If we were to uncoil it, how large do you think it is? How many feet? 20 feet. And that's a very small, structure. You've seen the models. And so uncoiled is 20 feet long.
Is that going to be on the fun?
No, it's just fun fact. A couple of, one thing is the ampulla is the expanded end of the vas deferens where it's going to meet up with the urethra. This will be the site of a vasectomy, which we'll talk about here in a second. Is it here yet? Not yet. We'll talk about here in the next slide is a vasectomy where it is snipped and tied or cauterized so that the sperm are never actually ejaculated. Now, the urethra, we said before that it's about 8 inches long, and that's not the penis size. The urethra is much longer than that. Hey, but there are 3 different pieces to the urethra. We have the prostatic urethra that runs through the prostate gland. There is a very short part called the membranous urethra, or it's also sometimes called the intermediate part of the urethra. And that passes through the urogenital diaphragm. The urogenital diaphragm is a thin piece of muscle at the bottom of your pelvic floor. So when they tell you to do like your Kegels and stuff, you're working out that urogenital diaphragm. And then you have the spongy urethra that actually passes through the penis itself. It's also called the penile urethra. You can use either one. The penis has these erectile bodies, one of them called the corpus spongiosum, which is why we call it the spongy urethra. But you can call it either one. That's going to be on your learn list today. Okay, any questions so far? Okay. So those are those structures or those ducts. So the vas deferens or ductus deferens runs from the epididymis all the way up and eventually we'll meet up with the urethra, and I'll show you where that happens at the ejaculatory duct. Yeah, that's it. And then the epididymis, they show it on here, yeah. The epididymis is the structure on the top of the testis that allows for that maturation of sperm. You can see it here on the side. You can see a much better image of the epididymis. It looks like the testes have a mullet, but it's that structure there. I like to make light of the reproductive system. And then we have the vas deferens, which again runs all the way up. And then you see how it gets larger here? That's that ampulla, okay, where it gets more expanded. And it's going to meet up with the seminal vesicle to make the ejaculatory duct, which will then meet up with the urethra here. So we'll talk about that in a second. Or we'll look at it one more time. Okay, again, epididymis here, vas deferens all the way up. It's going to meet up with, and here's the ampulla. It's going to meet up with this seminal vesicle, and it's going to create something called the ejaculatory duct. The seminal vesicle, which we'll talk about in a second, is going to provide fluid for semen. So this is where the fluid and the sperm come together to make the semen. It goes through what's called an ejaculatory duct and makes its way through the urethra. So this is the flow chart for, so go to the very end of the lecture notes. There's like a little blank spot at the very bottom of the end. There's a little star or asterisk around it. So this is the pathway. So sperm are made at the seminiferous tubule, pass through a structure called the ready testis, then to the epididymis, then to the ductus or vas deferens, and then and I'll specify and say the ampulla of the vas deferens and the duct from the seminal vesicle come together to form the ejaculatory duct. Then that now semen, because now the fluid portion and the sperm have come together, the semen now will travel through the prostatic urethra to the membranous urethra to the spongy urethra. And so I'll give you a second to write that down. And then for the membranous urethra, if it's easier for you to remember, you can call it the intermediate part of the urethra. And then spongy urethra can also be called penile urethra, whichever one that you are more comfortable with. Why did I ever realize prostatic, membranous, and spongy, that spells PMS? Which doesn't really make sense for males, but. All right, everyone good here? Okay. So this is a vasectomy. So how a vasectomy works is a small incision is made in the scrotum we pull out the vas deferens, cut it off, and then tie it or cauterize it. And so the sperm is still going to be produced. It's just it loses that duct. And so it just never leaves the male to reach the female. So what kind of birth control method would this be considered? Pre-fertilization, because the sperm will never meet up with the egg. So what's going to happen is that those sperm will just be deteriorated and phagocytized every month or so. But I mean, they're continually getting produced, so they're going to be continually being broken down as they get old. And so this kind of birth control with the testes remaining intact, testosterone is still being produced. And so this is going to retain the male's sex drive and those secondary sex characteristics. Reversals. So this is something that can be reversed, but a reversal is not always successful. Where did my pen go? Where did I put it? Oh my God. I would lose my head if it wasn't attached to my body. There it is. Okay, so reversals are possible. There is a 30 to 90% chance of successful pregnancy after a reversal, but there's a lot of things that factor into that. So it's going to depend on how long it's been since a vasectomy was done, the age of your partner and their ability to be impregnated, the surgeon's experience, so how well was the surgery done, and then any overlying fertility issues. Okay, any questions about a vasectomy? Yeah. And this is an outpatient procedure, so you can do it in a day. It's easy.
Since you said that the sperm doesn't even go anywhere, right? It just kind of stays there.
Yeah.
So doesn't it isn't there like an over or something there?
Well, like we said, at about a month of time, once they get about a month old, they get broken down. So they would just be continually broken down and recycled.
But that doesn't give them discomfort.
I mean, could. It depends, yeah. How active they are, I guess, but. Okay, cryptorchidism. Cryptorchidism is the failure to descend of the testes. So we talked about this last time, that during fetal development, about 6-7 weeks after conception, the testes are near the kidneys. And then they make their descent down, and they should fully descend about 4 to 6 weeks before the baby's even born. Sometimes that fails to happen, and they fail to descend, and that's when we have cryptorchidism. This happens in 1 in 40,000 males per year, so it's considered pretty rare. However, because the testes fail to descend, they're still in the abdomen, temperature is high, metabolism is high, it increases your risk of testicular cancer. And this is the most common cancer, so testicular cancer. So you have a higher risk of it if you have cryptorchidism. Is the most common form of cancer in men ages 15 to 35.
Are there environmental increase or decrease that rate?
I mean, genetics for sure, yeah, but if this is what we're talking about specifically is if the testes fail to descend, it gives you a higher risk.
Is it both of them, Professor, or just like one?
It could be one or both. It just depends. 96%, and we're still talking about testicular cancer, 96% of cases are cured or can be considered in remission with an orchiectomy, which is removal of that test, which may be combined with chemo and radiation. Make sure you remember how to spell it.
Orchiectomy?
Huh?
Orchiectomy?
No, cryptorchidism. Okay, any questions on that? Inguinal hernia. An inguinal hernia is when part of your intestines, due to pressure, escape out of the inguinal canal and end up on the outside of the body. This is due to weak abdominal muscles, depending on the situation, it may or may not be painful. But I can't imagine you at least not freaking out a little bit about your intestines being outside of your body. But it can be caused by coughing or bending at a certain angle or lifting. Obviously combined with that weak pelvic floor or weak abdominal muscles. And it may need surgical repair. Or they may just push back in. So that is an inguinal hernia. The intestines end up escaping out of the inguinal canal.
So it's still in your body.
Yeah, so the intestines, but part of it will come out. So this is a herniated loop of the intestines now on the external, and it goes out of the inguinal canal. Yeah.
So coughing, bending, and lifting,
Can cause an inguinal hernia if you already have weak abdominal muscles. So if you cough too hard, it can allow the intestines to escape, or if you lift something too heavy, it can allow the intestines to escape.
What if you squeeze really hard? Is that kind of-
Yes, that would be the same, yeah. But you have to already have weakened muscles, yeah.
if you've had it once, are you more susceptible to
Yeah.
getting it?
Unless you were to have it like surgically repaired, then that may be a...
So I know somebody who's had it surgically repaired, but he's been complaining that he's having he's calling them dental pains, but I'm like,
Yeah, he might, yeah, I mean, it could happen too. Surgeries sometimes fail and,
yeah.
yeah. All right, next are accessory glands. Accessory glands secrete the majority of the liquid portion of semen. So semen is, I think we actually talk about that later. But semen is going to be sperm, I think this comes up later, and secretions from the accessory glands. Oh, it's literally right there. Silly me. Okay. So our first accessory gland are the seminal vesicles. There are two, so you need to make sure you say left versus right on an exam. But they are paired glands at the base of the bladder. They secrete an alkaline, viscous fluid that accounts for 70% of semen volume. So 70% of the fluid for semen comes from this seminal vesicle. It's going to contain fructose. What kind of biomolecule is fructose? What is it? Carbohydrate, yeah. And it ends in OSE is a carbohydrate. Fructose, lactose, galactose. So the fructose is to provide energy for the sperm. The sperm have to live for a few days while they're on their journey to try to find the egg. And so the fructose is going to allow them to create some ATP to keep that energy high. Citric acid. This is used for coagulation and motility and health of the sperm. Prostaglandins are released as well. These are to help with erection. And before we get to the next thing, that coagulation. So at first, when semen is ejaculated, it's a jelly-like mass. And that jelly-like mass or that coagulation is actually going to keep the sperm safe from the low pH of the vagina. So the vagina or vaginal canal has a low pH to protect itself from bacterial infections and things like that. And so the semen stays coagulated in this mass as it goes through the vaginal canal, so it's protected from that low pH, because low pH can be harmful to the proteins and enzymes within the semen itself. And so at about 30 minutes after ejaculation, when that semen gets into the uterus and further up, maybe to the fallopian tubes, it liquefies. That way the sperm can then swim freely. So it stays as a mass first for protection and then liquefies so that the sperm can swim to the egg. Yeah. It's just like a glob of semen, but then after a while it liquefies. Yeah. Yeah.
Is it like the gel capsule, that you swallow a gel capsule and then in the stomach
It breaks down. Yeah. So the jelly-like mass for protection from the low pH of the vagina, and then liquefies at about 30 minutes or less. Also, it contains immune suppressors so that the female's immune system isn't fighting the sperm and thinking of it as foreign. And then enzymes are to help the sperm penetrate the ovum. And studies have shown that the female egg is actually selective with what sperm it allows to penetrate itself, which is pretty interesting. Women can be picky. And so, like we said, with that flow, the seminal vesicle will join the vas deferens to form the ejaculatory duct. So that's where the sperm, semen come together, and then it can flow through the urethra. Sperm plus secretions from the accessory glands. Yeah. Yeah. Oh yeah, that's what Jesus just asked. Isn't this stuff interesting that this stuff is like super more complicated than what you would think? And there's a lot that goes into it. It's not just sperm, it's all these other things that help the reproductive process. Yeah. No, you're fine.
between semen and sperm.
Semen is semen is the liquid portion, so all these secretions that we're talking about, plus the sperm together. So the sperm is just the cells with the tails that go and penetrate the ovum. But it needs the liquid portion from these glands that provide enzymes and food and all of that. And that together makes the semen. Yeah.
So you said that the vas efferens is where they like meet the semen and the sperm.
Uh-huh.
Like a pre-name, like a name before it's semen, because if there's no sperm, then it's not.
I mean, it's just secretions from those individual glands. And then once it meets with the sperm, then it becomes semen. They would just call them secretions. It's not like filtrate to urine, where it's like together through this whole entire duct. No, it's just going to be secretions from 3 different glands that meet up with the sperm to make the semen. Prostate gland is next. It's a single gland right underneath the urinary bladder. So there's no need for a left and right for the prostate gland. It secretes a slightly acidic fluid that accounts for 25% of semen. It contains citrate. This is another nutrient source for the sperm. And then enzymes, including PSA. PSA stands for prostate-specific antigen. Do you want to write that down? Prostate-specific antigen. And this enzyme is what's going to allow that sperm to liquefy after those 30 minutes. And so after it liquefies, then the sperm can swim freely. So the prostate gland is going to be responsible for activating that sperm after it's been ejaculated. Any questions about that? All right. Next is an enlarged prostate. It's called benign prostatic hyperplasia. This is pretty common. It happens in 50% of males in their 50s. 80% of males once you reach your 70s. And so as you get older, it may get harder to urinate from an enlarged prostate because what happens is that part of the urethra narrows and then it's harder for urine to flow. So it constricts the prostatic urethra, which is going to cause urinary retention, which can lead to UTIs or kidney damage. What is it called when urine backs up into the kidneys that we talked about with urinary 1? Hydronephrosis. So that's why it can cause kidney damage, because if the urethra is constricted and urine isn't allowed to flow, then you're going to have backflow of urine. And if it gets all the way back up into the kidneys, it can cause hydronephrosis. Treatment. Treatments would aim to lower testosterone, so like testosterone blockers, because testosterone is what contributes to prostate growth. And so if we lower testosterone, then the prostate won't be triggered to grow. Also, treatment is aimed to relax the smooth muscle of your urethra so that it makes urinating easier. You may even need to widen the urethra with surgery if it gets bad enough. So an enlarged prostate doesn't necessarily mean cancer. That's why we call it benign prostatic hyperplasia. But it can. So prostate cancer is the third most common cancer, third most common cause of cancer death, actually, in males. And that's the symbol or shorthand for males. Prostate cancer occurs in 1 in 6 men. Now, what we used to do is we would do a PSA test, so that prostate-specific antigen. We would do a prostate PSA test to see if levels were high to indicate prostate cancer, but that would give a lot of false positives. So we no longer use a PSA test as a form of diagnosis. What they may do is a rectal exam to go up and look at the size of the prostate, and then probably do a biopsy to test for cancerous cells then.
Biopsy of the
Prostate itself, yeah. Many of cases of prostate cancer are slow growing. So it's kind of like a wait and see as far as with surgery, chemo, and things like that. And then another clinical note on the prostate gland is prostatitis, which is just inflammation of the prostate gland, which may be due to an infection. Common infection that causes prostatitis is E. coli. And what kind of organism is E. coli, or microorganism? The bacteria. So you'll know it's like that. Well, bacteria usually have like a species and a genus name, like E. coli, H. pylori. Viruses tend to not, because they're not real, or they're not really alive. They're not considered alive. So we don't give them species names.
zombies.
Yeah.
And that's treatable, right?
Yeah, prostatitis? Yeah. Like any other bacterial infection. Next is the bulbourethral glands, or also known as the Cowper's glands. They are a pair of pea-sized glands inferior to the prostate on either side of that membranous urethra. So they are on the models that we'll see in class. And they're going to secrete an alkaline mucus just prior to ejaculation, so pre-cum. Okay? Because you should know that the urethra is used for both urine and for ejaculation. And so the urine can make the urethra acidic or a low pH, which can be harmful to sperm. So that's what the pre-ejaculation is for, to neutralize the acidity in the urethra. And so this is going to account for the last 5% of semen volume. Any questions on those glands? Okay. So these are all those glands. You have the seminal vesicle here that meets up with the ampulla of the vas deferens. And when those come together, that forms the ejaculatory duct here, which is then going to merge with the prostatic urethra. Then we have these here's a prostate gland here, and then the small bulbourethral gland, or Cowper's gland. Same thing over here. The ampulla of the vas deferens meets up with the seminal vesicle to form the ejaculatory duct, which runs through the prostatic urethra where the prostate is. And then here are those small bulbourethral glands. All right, so again, semen, and you already wrote this down, I believe, is sperm cells plus secretions from accessory glands. The secretions are going to provide, one, a transport medium, so fluid for the sperm to travel in, nutrients, chemicals that aid and protect sperm in their movement, dilution of sperm, and then a clinical note on male infertility. Sterility is likely if the sperm count is less than 200 million per milliliter, which seems like a lot, but it's all by chance. And so if you don't have literally hundreds of millions of sperm, you're not going to ovulate the egg. Also, if they were to look at the sperm underneath the microscope and more than 25% of the sperm look abnormal, then that person would more than likely be sterile.
Abnormal as in like the jello is missing and stuff?
Yeah. All right, so last thing, or second to last thing, we'll talk about sperm last. But the penis is going to deliver sperm into the female reproductive tract. It consists of an attached root. This is going to be the part that's still internal. The free shaft or the body. And then the enlarged distal end, which is called the glans penis. Or you could just call it the glands. That would be considered like the head of the penis, but we call it the glands. The internal structures are going to be the erectile bodies. So we have the spongy urethra and then these 3 cylindrical bodies of erectile tissue. We have 2 what are called corpora cavernosa. And that's talking about both of them. If we're only talking about one, singular, we call it corpus cavernosum. But there is 2. So those are the 2 erectile bodies that are on top of the penis that fill up with blood and allow the penis to stand erect. And then there is a single corpus spongiosum, and there's only one of those. So engorgement of these bodies are going to result in an erection. A clinical note is Viagra. Viagra, what it does is it dilates blood vessels to allow for more entry into the penis to allow it to stand erect. A funny fact is actually Viagra was first used as a hair growth treatment because it dilated the vessels in the scalp to allow for hair growth. But then they noticed a very obvious side effect, and they're like, oh, this is a much better way to market it. So they rebranded it as Viagra.
So does it make your hair grow?
Yeah, and there you go. Because it's dilating blood vessels everywhere, so you're going to get more blood flow, not only at the penis, but the scalp too. That's what it was originally intended for.
2 for 1.
2 for 1, yeah. All right, so this is those bodies here. So the corpora cavernosa. Oh, here, that's better. The corpora cavernosa, it's Latin. If you really want to, you can call it the cavernous bodies. That's what it means. Corpora is bodies. And then cavernosa, the cavernous. But the corpora cavernosa are the 2 on the top. So those are the 2 large erectile tissues. And so those are the ones that are going to allow the penis to stand erect. It makes the penis top heavy, and so it stands up. Then we have a singular, smaller corpus spongiosum that surrounds the urethra, which is why we call that part of the urethra the spongy urethra. So in English, you can call it the spongy body. But Latin is so much more fun. Say it again?
Do we have an left and right?
Yeah, so you'll have a left and right corpora cavernosa, or corpus cavernosum, if you're talking about one. There is a left and right, but not for spongiosum, because there's only one of them. All right, so ejaculation, this is a parasympathetic reflex. The parasympathetic nervous system dilates the blood vessels in the penis so that it can stand erect. But then the sympathetic nervous system induces contraction of that smooth muscle, which is going to squeeze the semen through the penis and allow for ejaculation. So you learned in B32 that for ejaculation and orgasm, that's the only time when your parasympathetic and sympathetic nervous systems actually work together and have cooperation with each other. The prepuce is the foreskin. Clinical note is circumcision, where that gets surgically removed, usually when you are an infant. Now, getting a circumcision does have health benefits to it. One, it's more hygienic for a small child to have a circumcised penis, but also 60% of U.S. newborns are circumcised, and it lowers the risk of HIV and lowers the risk of other reproductive infections. But not everyone chooses to do it for religious or other reasons. But it is more hygienic, and it does reduce the risk of infection.
So what's the purpose of foreskin then, like, why
That I don't know. I'm not really sure. Structural thing, genetic thing. I'm sure there was a purpose for it at one point, yeah, in our evolution. And then where the exit is the external urethral orifice. Hey Siri. Oh, it won't do it when I'm recording. Never mind. I'll ask her later. Okay. Any questions about the penis? Okay. Last thing is sperm cell composition. So sperm has its own anatomy too. So we have the head that contains the nucleus where the DNA is going to be to allow for the haploid sperm and the haploid egg to come together and combine their DNA to make a zygote and eventually an embryo and eventually a fetus. The acrosome is the very tip piece that's going to allow the sperm to penetrate the ova. It literally has to dig its way through into the egg of the female. Then we have the mid piece of the sperm. This contains all of the mitochondria that's going to allow for the ATP production to allow the sperm to live for 5 to 7 days in the female reproductive tract while it's trying to look for the egg. And then the tail or flagellum is used for locomotion. And the sperm is the only instance in humans that we have that flagellum. So only in sperm, that's it. No other part of any male or female will have a flagellum. And so here's that. Here's the head here. Acrosome is the tip. Then we have the nucleus that'll have the DNA. Here's the mitochondria in the mid piece. It kind of wrap around that mid piece. And then the tail is the flagellum. Flagellum is a single one. Flagella is multiple. Okay, any questions? That's it for males. Flagella is plural. Flagellum with the UM is singular. So I'll stop that recording and we'll do